Careblazer, imagine this. Imagine you're caring for a loved one who starts to have memory problems, has difficulty putting together their words, seems more confused than ever, to the point that their medical doctors now believe your loved one has dementia. Then imagine there was a test that is accessible, available right now, that discovered the person didn't have dementia at all. It's just that their own genetic makeup created a bad interaction with one of their medications. This is a real life story. This is happening to people out there in the world right now. And today I had the pleasure of sitting down with my friend, my neighbor, and one of the top renowned pharmacists in the world, Dr. Adrijana Kekic. And she sits down with me and we talk about something called pharmacogenomic testing, how we can get it for ourselves, how we can get it for our loved ones, and how this is the future of personalized medicine. To think that all of us at different ages, different genders, different health conditions, taking different medications would all react the same to the same medication is quite frankly absurd. Yet this is the way we treat medications and healthcare right now in our country. So this is an eye-opening conversation. I learned so much. Please make sure you leave lots of love and support for Dr. Kekic and enjoy this conversation. She had to walk a whole 10 steps to get to my house.
Adrijana Kekic, welcome so much. I'm so glad you're here. It's an honor to have you as a neighbor, as a friend, but especially to have you here and share your professional insights and knowledge with our Careblazers. Can you take a moment and briefly explain who you are and what you do?
Well, first of all, thank you for the invite. It is my pleasure, really, my honor to be a friend and a colleague of this exceptional human being, Dr. Natalie Edmonds. We get to chat about something that I know both of us are quite passionate about, but something that is my favorite topic of discussion, that is drugs, prescription drugs, over-the-counter drugs. So why is that? What do I do? I'm a pharmacist by training. I'm a doctor of pharmacy. I do something called pharmacogenomics. And maybe some of you have heard about this term, pharmacogenomics. Essentially, what that means is that I study how our genes, our heritage, affects the way that we respond to medications. I've been in a pharmacy actually field for a couple of decades. My niche, or I'm board certified in ambulatory care. So I get to see patients from all walks of their clinical lives. And my kind of sub niche would be psychopharmacology. I lecture on psychopharmacology to both medical students and pharmacy students. This became my love, even though it was not a love at first sight. It was kind of a roundabout way that I arrived to that. But psychopharmacology essentially would be drugs that we use that can have something to do with our brains or minds. So think about maybe pain medications, migraine medications, antidepressants, Alzheimer's disease, and so on.
Yes. Okay. And you mentioned a very fancy word, pharmacogenomic.
Yeah.
Okay. First of all, before getting into a scientific explanation, can you tell a story? Because I really want the Careblazers at home to understand why this is so important and why this is the movement of prescription drugs of the future. Explain this.
Good, actually, question. And I think this is probably the best for us to start. Why is this important? What is this thing called pharmacogenomics? And why is there more chatter about pharmacogenomics? So, as I mentioned prior, pharmacogenomics is just a fancy word that we say pharmacology, which is drugs, and then genetics or genomics. And I think most people will recognize genetic or genomic part. It has to do with our DNA. It has to do with our heritage. So why is that important? Well, it turns out that most of us, just like we differ in terms of our build, eye color, hair color, different things within our body, we also differ in terms of how we actually react to medications, how we respond to drugs. And I think for most of us, again, this is going to be intuitive because maybe you have a family member like I did or do, or maybe even a friend, colleague who will take a medication that maybe you took, and you're going to have a very unexpected reaction. And they'll say, no, I was perfectly fine. No side effects. It worked well for me. And yet here you are, you're having all of these reactions and you don't know where they're coming from. Well, a big part of these reactions, either side effects, meaning medications are causing issues, or maybe medication not working. That's another thing, are greatly influenced by our heritage, by our DNA, by our genes. So I can share a personal story, and this happened to be around the time also when I was really bringing pharmacogenomics into the clinical practice. I work at one of the leading institutions in the world. I was very lucky to be able to do this, with my patients clinically. My dad had colorectal cancer, and as a part, perhaps some of you also can relate to this. When you're diagnosed, it's very overwhelming to go through the process. And then all of a sudden, you're a person, and all of a sudden, you become a patient. You have this label. So there is a lot that you need to kind of just go through and figure out what's going to be the next step. Well, as a part of this next step, his oncologist suggested two things: that we kind of figure out the tumor, meaning the cancer, did it have certain genetic mutations? And why is this important? Because some of these mutations can make chemo drugs not work, and we want to be able to identify that so we can give him a different medication. That was one of the things that we did. And the second thing that we did that his insurance company did not pay for was pharmacogenetic tests. And why pharmacogenetic tests? Well, genetics our DNA can give us a very intimate look inside of our body to say, how are you built? And is your body able to fully metabolize, if you will, or process these medications? And sometimes it's not. So what happened with my dad is, yes, we gave him the right treatment for the cancer, but very shortly, he broke out in massive rash. He was not able to hold the food down. So bunch of other things. We ended up paying for this pharmacogenetic testing out of pocket because I thought this has to do with this drug, obviously. And it turns out that it did. So he had a rare mutation, meaning kind of like to do with your genetics, that for his body made this drug toxic.
Oh, wow.
Even though it was the right treatment, his body did not know what to do with it. And it went into overdrive and it made it toxic. And he unfortunately struggled greatly. We stopped, went to a different medication, and that resolved.
Wow. Okay, I have so many questions.
Yeah.
Number one, let's say most people don't get pharmacogenomic testing, which I think is a shame, but most people don't have that, right?
Mm-hmm.
But if somebody had a negative reaction, like breaking out in hives all over, then some people could argue, well, we would just stop it anyway because it was such a bad reaction. So can you tell us why it would be important or how that testing makes a difference if side effects would probably dictate another move anyway?
Excellent question. So buckle up a little bit. We're going to go into nitty-gritty detail here. So typically when we do the pharmacogenetic testing, we're not checking only one thing. Okay. Humans have over 20, close to 30,000 genes. And there are many different ways that those genes can differ from one person to another person. Mm-hmm. So when we do the pharmacogenetic testing, we're looking at several of these genes. I mean, we can scan all of them. It's just that not all of them have to do with drugs. So we really zoom into those that have something to do with medications. And there is a lot of evidence, meaning lots of studies, and we know a lot of data behind these genes. So when we do this testing, it's not going to tell you only how you respond to one drug. It's going to tell you how your body responds to hundreds of different drugs. Mm-hmm. So what we actually discovered with my dad, I suspected, but we don't know until we do the testing. He would get, for example, medication that has codeine, like for dental work. And codeine, if you're not familiar, is basically a pain medication, but really what it is, it's a cough medication, cough suppressant, until you take a pill and the pill gets, dissolved in your gut, and then blood takes it over to liver. Well, in liver does its magic, does its job, and transforms codeine, cough suppressant, into morphine, which is a pain medication. So there are people who have this genetic thing that makes that so-called drug metabolizing enzyme not work. Some people don't even have this drug metabolizing enzyme even built. And we're just blindly having them take these medications. That's what happened to my dad. And actually, we uncovered through this testing that the reason that he would get shortness of breath every time he took medication with codeine is because his body was converting codeine into morphine at extraordinary rate, and morphine basically suppresses your breathing.
Wow.
So we unveiled all kinds of things, not just related to chemo drugs, but really kind of like peeling the layers and taking a peek inside of his body to say, how is your body built? So we're not going blindly into just prescribing these meds.
So it's informing future prescription
Future
decisions.
prescription medications. Yeah.
To put simply, and please correct me if I'm wrong, the pills are the same, the medication is the same, but the moment it enters a person's body, it's no longer the same. It's going to be different based on that person's genetics. And that's why some people have bad side effects, some people don't notice anything, some people have wonderful response. And if you don't have this testing, it's basically just a guess. Take this pill, and then we'll just, based on what you say and what we see, we'll determine whether or not it's working, but we don't really know.
I'll just take you with me and you'll do my presentations for me because you put it in so correctly and so nicely. But that's essentially what's going on. Think about like where we are right now. We're just guessing how Natalie, Adriana, or whoever else needs a medication. We're guessing how people are going to respond to them. So what works for some could be a poison to another person. What works for some may not even touch or work for another person. And this is very much driven by genetics. Now, mind you, genetics is not end all be all. There are many different things that can, contribute. Presence of another medication can greatly affect how that first medication, for example, is going to work or not going to work.
Yeah, this seems so clear and so obvious that our own genetics would impact medication. Yet, why doesn't everybody get this testing? This seems like this should be like a standard practice for everybody. What's the story behind this?
Wow. Pause me when I have exceeded my welcome.
Well, because I imagine people at home are like, I know they're caring for people who have had a bad reaction or don't really know if something's working, and they would love this type of testing, but it doesn't seem widely available. I know I would love this testing because I could take a Tylenol and I will like shake. I have like the worst reaction to any type of medication. My husband is always like, eat a buffet of food before you take a vitamin, because I just can't take it, So I'm like, oh, I wonder what I have going on inside of me,
Yes.
But so explain maybe why this isn't available, because it seems like it would be super helpful for reduced adverse events and all of these things for the hospital system as well as the patient. What's going on?
So we totally could have even a conference about this whole thing, but really you ask a very important question, and a question that I get asked all the time by physicians and providers and family members as well. It's not unusual for me to meet with a patient, and all of my consults, by the way, are virtual consults. So I will meet with a patient. We're not sitting even in this proximity, yet there is something deeply personal about that experience, because up until that point, most of us have not had any sort of genetic testing done. We have no clue, really. We can have indicators through the blood work that we do and whatnot, what might be going on inside. So it's not unusual when I meet with an individual that they'll say, oh my God, my mom and my dad should have this testing done. They are taking all of these medications, be it for, I don't know, blood pressure, cholesterol, GERD medications, medications for pain that are not opioids also, whole shebang of things, and they're having these difficulties. Also not unusual for me to hear my daughter or my son should have this testing done. And I hear and I see tears oftentimes, because up until that point, a lot of people feel like they're not seen or heard based on those experiences that they've gone through. This is kind of a side note, not necessarily maybe targeting individuals with dementia or people who care for them, but perhaps people who care for family members with dementia, maybe even those with dementia, especially women. Natalie, I see this a lot with women who will say, no matter what medication I take, it just affects me. I'm going to pass out. And so majority of the patients that I see just by this are women who have medication difficulties. It's not in our head. This has to do with our biology, and we're just gathering why. So to go back to your question as far as the standard of practice or not, it's not a standard of practice in the United States. That same genetic testing that I had done, the gene is called DPYD, and I'm so sorry, this is just, I promise, it's going to be very short detail if somebody is interested in what the gene is. And it has to do with the medication chemo drug that's called 5-FU, difluorouracil, and capecitabine. So these drugs, before you get them in Europe, it's mandatory for most countries that you have this testing done. Why? Because people have died from these medications having this genetic mutation the same way that my dad did. Many of us actually have this without knowing that we have this. In United States, right now, we are luckily, and I'm feeling positive, enthusiastic about all of this, we're seeing this shift finally from going from one size fits all trial and error type of, how do we do this, to really so-called personalized medicine. And pharmacogenomics is that one test that we do in personalized medicine to say, oh, well, what does that look like for you? So it's not a standard of practice. One other thing that I'm going to mention, and this might be of interest to people who say, okay, you sold me or you have not sold me. How do I go about getting this testing done? You can do it through your physician. You can do it through institutions or hospitals or clinics. You can also do it direct to consumer testing. Word of advice with direct to consumer testing, you have to make sure that you read the fine print to understand maybe what you're getting. Perhaps leverage your pharmacist or physician before you would do that. The testing can be done, and it's one lifetime test. So you do it once. Whatever was found on those genes, that's not going to change. Kind of like your eye color, it doesn't change through life. So if you have a mutation, you have a mutation. If you don't have a mutation, at this point, what that means is that we simply don't know if you have any other mutations that we don't check for right now. And the test is anywhere between $200 to $500 typically.
Okay, wow, that seems pretty practical given the information that you
Given
would
the
gain from it.
impact that this provides, even if the insurance company doesn't pay for it, Natalie, I would say 99.9% of people and patients I have worked with, and I work community setting, this hospital setting, they have paid for the test out of pocket. We have paid for the test out of pocket when my dad had the testing that the insurance company would not pay for. The good news is now the insurance companies are finally catching up because the evidence is so overwhelming, and we have guidelines.
Yeah.
So now there are guidelines to say, if you have a mutation on XY gene, you should not be prescribing that medication, or you should get a 50% of the dose that somebody else without that mutation is going to get.
Which makes so much sense. And I imagine in the long run, it actually saves money for the insurance company.
Absolutely. We already have studies
Yeah.
that show that money saved is amazing in comparison to the cost that is needed for the testing and interpretation.
Now, you work at one of the leading institutions in the world. Do you think this information and knowledge about this testing that's available is common knowledge among most physicians and providers?
No.
Yeah, okay, that's what I was going to say, because
No.
I'm going to say, Careblazers, if you're interested in this, you're probably going to have to be the one to bring it up with your healthcare provider there, and they might not actually know about it.
Absolutely. So two things that come to mind immediately. So to add to what you just said, so no, genetic literacy remains low, quite low actually, in healthcare community. And this is something that needs to be changed. And we're already seeing that change, like in medical school and pharmacy schools. This is a part of curriculums. So every new generation that comes through will have better insights, can advocate better for their patients and so on. The second thing is, and this is I would say this is across the board, that I have seen a year. I've been doing this particular thing for almost a decade now, and I see this all the time. It's typically patients, sometimes it's physicians, actually. I cannot say that it's not, but it's typically patients who will come and say, I had my genetic testing done. I want my family members to have their genetic testing done. Or a friend of mine had it done. I would like to pursue this. One huge resource, folks, that you have in your community. Now, mind you, when I say this, I understand that I'm biased, but one huge resource are going to be your fellow pharmacists. Because what pharmacogenetic testing is, it's not genetic testing that is going to tell you if you have an increased risk of a certain disease, although it can, but this testing is going to tell you what does your body do with the drugs. And so pharmacists are usually the resource freely available in most community pharmacy settings that at least will tell you how would a medication be affected by a certain gene. Most of them will have that insight. Most of our physician colleagues struggle with that because it's genetics plus it's pharmacology. I always say pharmacogenetic testing is pharmacology, which is a study about medications, is pharmacology on steroids, because you're getting this deep insight into your pharmacology capability of the body.
Okay, you mentioned it, but I was thinking in my mind, are there ramifications of possibly getting this testing in terms of possibly qualifying for like long-term care insurance or life insurance? Could something pop up on this testing?
Yes.
Okay, so that's good to know.
Yes. So we probably should pause here and just educate people on the following. So the pharmacogenetic testing and most of the genetic testing in the United States, you are covered by a law or regulation, if you will, that's called the GINA, Genomic Information Act, that rolled out in 2008 or 2009 by Bush administration. So translated, what does that mean? Well, it means two things. If you do the pharmacogenetic testing, I'm going to speak about that. Your insurance companies should not be able to use this against you. Like your employer, third-party insurance, like, I don't know, Blue Cross, Medicare, or whatever. However, your life insurance can. So this should still be a consideration. This is why I'm saying be very careful if you're going direct to consumer route. There are different platforms, but many of the platforms, Natalie, that I see, I would not recommend them. And the reason is they will sell that information to third parties. That information, understand the genetics and all of these molecular insights are the deepest insights of yourself. So as a patient myself, and I have had various genetic testings done, I prefer to keep that either at an institution that's going to protect that for me from the third party access, or really keep it to me.
In your experience, have you ever heard where a provider may not want to order that testing?
Yes, many times. So many times. And what is the reason for it? Well, first, low genetic literacy, because a lot of times, and I work with the most wonderful physicians, both in the community and obviously now at where I work. And it's not that they are trying to gatekeep it. It's just because first of all, they themselves may not be educated as far as what this genetic testing really can do in terms of these insights. How is it going to help them make your life better? The second thing has to do with a lot of these tests that are out there, especially direct to consumer, are snake oil stuff. So they may have exposure or touch points first with that sort of a test before, like this testing that I'm talking about, and they'll just say, I don't feel comfortable. Third thing is they feel like if they order the test, they're going to be held reliable. There's a liability portion there. Who is going to act on those results? Even though I may not be prescribing the medication that this genetic testing just unveiled. Let's say that you go to see a pain specialist or maybe cardiologist. And they're like, yeah, I can prescribe what I prescribe, but I have no clue what the rest of this means.
Yeah, I'm imagining now it's also, I mean, it's an amazing resource, but they should be looking at what those results are before they make any prescription decision.
I think that's where we're headed.
Okay.
That's exactly where all of this is headed. And I know that we are kind of painting a little bit of a mixed picture. On one end, you have this promising tool, that some of us have used or some of us maybe are even doing it right now. And then on the other end, you have all of these questions that are still hanging. What do we do with all of this? I think the bottom line would be this. And if I'm going to say anything with clarity, I would say the following. If you have medication that you need to take, or you're currently taking them right now, and from what I have seen, most people take more than one medication. Okay, so I would say, as opposed to blindly guessing what your body is going to do with that medication, I think it would be excellent and ideal that you start with your foundation. And your foundation is exactly your genetics. Again, genetics is not end all be all, but it's really informative, to give you the insight. Could you potentially do something or not? And if you cannot, then we can figure out the way, how do we go about that? So that's the first thing. And then the second thing is, this is not an exact science, it's still an art. So a lot of what our experiences are with medications also depend on what you do in life. So environment, so food, like all of the regular things we talked about. But one thing that I see a lot, that's a huge issue in the clinic, are drug-drug interactions. And I especially see it with elderly, because a lot of times we think taking an over-the-counter medication or natural supplement or supplement period is going to be better than a prescription medication. Sometimes it may, but a lot of times it's not, because all of those things are pharmaceuticals, either pharmaceuticals or supplementeuticals or whatever. We're asking our body to continuously work on metabolizing them, processing them, and then you're adding a mix of the things that we don't know how they sometimes even play together. So this is a huge thing that I see, especially with elderly, because they take more medications. They take medications that can address maybe several chronic conditions, be it, I don't know, blood pressure, having a high blood pressure, high cholesterol, aches and pains with, diabetes, of course. And then you start with medications that can have something to do with mood, with anxiety, with sleep. We're talking about a pharmacy
Yeah.
that you open up in your kitchen cabinet and say, okay, what do I choose from this that is going to be safe for me?
Right. So I'm hearing overall there's kind of two big things if people were to get this testing. Number one, actually finding a safe, good, reputable way to get the testing. And then number two, having providers that know what to do with that testing.
Exactly. You
Okay.
said it absolutely right.
Okay. And I have, you're teaching me so much. This is so
Oh.
fascinating. So thank you. I have a
My
question that might not be a correct question because my knowledge might not be there with the genetics. But since it's genetic testing and you mentioned like it shouldn't change so much the medications that you could be prescribed based on these results.
Mhm.
How does epigenetics play that role in terms of like we can maybe turn on some genes or turn off some genes? Like, does that change in the future? Like, would that change potential prescriptions or no? This is pretty much set in stone. You can rely on this forever.
Epigenetics is essentially how environment, anything external and also even internal, can affect the way that your genes get either expressed or not expressed. I'm going to use a terrible, terrible metaphor here. And I apologize for this metaphor. It's just the first thing that came to my mind. So they usually say that the genes are kind of like a gun that you get based on what you got from your ancestors. And that epigenetics is essentially the thing that pulls the trigger. In other words, you can have a predisposition for cancer, Alzheimer's disease, whatever that might be, schizophrenia, bipolar, doesn't matter. You can have a predisposition for that and yet not get it. We know this even with twin studies. So you can have two individuals with almost identical genetic predispositions, and one is going to do, all of those healthy things that we say that you should do in life. Stress is a huge component of this, and we're only learning how stress actually overrides some of the protective things that we get also from our genetics and how it triggers these risk genetic factors that we may have. But all of this basically can override in a way. That's why I'm saying it kind of pulls the trigger to say one twin is going to develop a disease, but the other twin is not.
Yeah.
So it plays a huge role. That's the first answer. The second answer is we still don't know how. So the science is still science is there, but the clinical part, like if you go to your doctor or if you speak to your specialist or a pharmacist and say, okay, can we order the epigenetic testing and do the epigenetic testing for me to tell me, what overall, my body is going to be capable of? I guarantee you 90% of the time, if not more, they will just say, I don't know really what that is, and I don't know how to act on that. So there is that component, but the promising part is all of this is coming and how the technology continues to advance. I cannot quote you if it's going to be 2, 5, or 10 years from now, we're going to have all of these algorithms, computer systems that will be able to scan all of these. Through the testing, you're going to be able to take your genetics, epigenetics, and all these factors of self and then kind of figure out, oh, well, maybe what we now call Alzheimer's disease or dementia or heart failure or blood pressure, actually, that's not what it is.
Mm-hmm.
Based on these molecular things of yourself, this is what you have.
Mm-hmm.
And then we match you to the right treatment that's actually matched only for you as opposed to somebody else. So that's how epigenetics is going to continue to play a role in all of this.
I think that's amazing and fascinating. And I hope that becomes common practice at some point in our lifetime for sure. It just makes so much sense to think that everybody is supposed to react the same exact way to the same exact treatment. Doesn't make sense. And also I feel a lot, especially in dementia care, it's really a guessing game about what's going on. It's like, oh, you have these symptoms. Okay, take these tests. Okay, well, you performed in this area. Okay, we've ruled all of this other stuff out. Okay, we think you have this type of dementia. It really is not like a very confident, secure knowing.
It's really not, Natalie. And really, if we are to kind of dig a little bit deeper, even we know, again, I mentioned, how men and women respond differently to drugs. I especially see this in also 2 stages. Women that are going through hormonal kind of peaks and valleys, so perimenopause and menopause, I especially see it then. They may say, I was able to tolerate this medication when I was younger, but I don't know, for some reason I cannot now. And the second stage is we know that genetics, of course, plays a role, but sex also does, and so does age. And men and women also age differently. And by the way, you mentioned epigenetics. You can have somebody who has a normal expression of these drug metabolizing enzymes that I mentioned. Like you can think of them almost like these metabolic pathways or roads. And so each one of us should have 2 lanes in that road, That's what the normal thing metabolic pathway would look like. Well, you can have that as a woman, but then you get pregnant and you no longer have 2 lanes in that road. You have a mega highway. So you start metabolizing things quicker. And then on some other roads, that road may shut down during the pregnancy. So this plays huge role, again, not only for women, but it does for men, especially as we age, because organ function change. Like your liver doesn't work the same way as it did 10, 15, or 50 years ago. So in respect to maybe what I see a lot of times in long-term care facilities or dementia care facilities, again, I go back to the same thing that I mentioned. Even if we don't do the genetic testing, we need to make sure we're not over-medicating people. And I see this, Natalie, all the time. I'm not going to even, like, we could go down the path of mitochondrial function, which greatly diminishes as you age. And then you add all of these medications that can further reduce the function of mitochondria. Mitochondria are basically parts of every one of our cells that provide cell and us, all of the parts of us, energy. They do many other things, but energy. And so think about what we're doing. You already are losing your precious energy. And sometimes we're just overburdening people with pills. And that's a problem.
Absolutely.
So we have a huge problem in this country when it comes to that.
Absolutely. Okay, I want to clarify something. This pharmacogenomic testing, it's not the same testing as if somebody was going to go find out if they have one of the rare Alzheimer's disease ones. Okay, that's not even tested for or included.
Correct.
Okay.
It's not. I'm so glad that you brought this up because I forgot to mention that. So pharmacogenetic testing will stay in its lane, and the lane is drugs. What your body does with drugs.
Perfect.
There are some slight nuances, like for example, it can test if a person will have an increased risk of blood clots. They're called F2 and F5 genes. Why do I mention this? Well, we know, again, and please don't think that I'm biased. It just happens to be that women also can be at increased risk of blood clots because it's estrogen-driven thing, you know. And if you take hormone replacement therapy, like an oral birth control, and I see oral birth controls prescribed or hormone replacement therapies prescribed not only in 30s, 40s, and 50s, but women too in their 60s and 70s. And sometimes it's appropriate. I'm not saying it's not. I'm just saying if you have a genetically speaking increased risk of blood clots, you're going to have to be very careful what you do to ensure that you don't actually get them.
So to wrap up, this has been so helpful. I'm so appreciative for your time and all your knowledge. I'm wondering, I'm just thinking for myself, like I want to make this a goal by the end of the year to get my own testing. And I imagine there's people watching right now that want their own testing or even for their loved one. What's the best way to go about it? Just start with your primary care provider?
I'll answer your question, and I don't want to lose the thought that I just have in my mind. I have put together some resources, and I'm happy to share them also
Thank you.
with all of you who are listening or who are interested. I have some resources that you can say, oh, I want to do the testing. Which testing platforms? Maybe I can even go back to my physician to say, hey, listen, I found out about this. What do you think? Should we go with this one? If your physician does not know, I kind of have my ratings, and this is not to do with the company that I work for, just has to do with me as a patient and a healthcare provider, what I have seen. So I can provide kind of the top 3 or top 4. If you go to speak to your physician, you can take that with you and say, you don't have to guess, here is maybe where we can start. Some physicians may even know. But I also have kind of a list of few of the colleagues that I work with here in the Valley, especially if you're in Valley, meaning Phoenix or Arizona, who, if you do the testing, they can set you up for the testing. They can interpret the test results for you. Again, please don't think that I'm not promoting anybody.
No,
I just know these are the
Yeah.
questions that I get all the time, and I cannot help them because they're not my patients. However, I want people to benefit from this, yourself, your husband, whoever else is included, so they can do this testing in a way that they know that they're getting good quality and they're getting actually something that's really meaningful as opposed to some sort of a snake oil stuff.
Right.
Yeah.
And it's so easy to fall to a lot of those snake oil things because we're desperate, especially when we're caring for somebody with dementia and we're trying, what is being prescribed doesn't seem to be doing anything. We want to try anything.
I'm going to tell you what recently happened. First of all, I had a patient who came to see me. After that, she scheduled her mom to see me for the pharmacogenetic consult. We do the test and then I do the consult. consult. It's a full hour consult that I do with the patient, and we go through everything.
Mhm.
Their diet, their meds, their supplements, and of course the genetics and all of these other things. What happened? This patient has been treated, Natalie, for dementia. So she came to us for second opinion, essentially. So for dementia for over a year. We did the pharmacogenetic testing to basically find out she does not have a road that the medication that was prescribed to her. And by the way, this medication sometimes I see frequently prescribed. It's called amitriptyline or nortriptyline. Its cousin, close cousin. These are so-called tricyclic antidepressants, blah, blah, blah. It's a long way to say these drugs are used to help not only with depression. No, they're usually used to help with pain.
Mhm.
And so as opposed to giving somebody an opioid medication, a lot of times they'll prescribe this medication. By the way, amitriptyline is not recommended for elderly to start with
Mhm.
because of what it does within the body. It has a lot of side effects.
Mhm.
One of the most common side effects is what we call central nervous system side effects.
Mhm.
Confusion, reduced mental acuity, difficulty with just completing your tasks, and so on. So
Is that the
this
same as anticholinergic effects?
anticholinergic effects, dry mouth, you just have these mental changes and all of this. So the patient also had difficulty urinating. And of course, they gave her a medication for the bladder, to help with the bladder. So it was a slew of medication when I came to see her. Well, it happens to be she has this one mutation that affected 4 of the drugs, including the first drug that was prescribed for these. Well, actually, amitriptyline was prescribed for pain, and then it started causing these dementia-like symptoms, but they just thought it was dementia-like symptoms. So the long story short, the patient could not metabolize this medication. This medication became toxic for her and caused all of these issues for which she was treated with additional medications. So of course, she stopped, and guess what happened?
She got better.
All of the symptoms resolved. So we prescribed a different medication to treat, again, non-opioid medication to treat this. But that's one example that I recently had. And her daughter, you can imagine the impact of this. And the daughter came into the consult because she was having difficulty stringing sentences. And you could just see her daughter's tears, just relief that, oh my gosh, that's what it is, as opposed to something else.
Talk about life-changing. It
Absolutely.
makes me think about people out there right now who have been written off as you have dementia and there's nothing we can do about it, when they might just be on some of these medications that don't work for their body.
Absolutely. And again, I'm not saying this is going to be like this for everybody, but imagine if that was really you or a family member or a friend who knows or somebody that you're treating. I mean, this is why I'm saying very biasly, but not biasly, that anybody who takes a drug, be it a supplement, be it a prescription medication, really should have this testing done, just so you can understand at least baseline what some of this is. And again, I'm going to underline this. This is not end all be all. We are not testing for all of the genes. We are not testing for epigenetics. We're not testing for metabolomics. All of these big words, basically meaning molecular tests. They're really advanced. But all of this is coming.
I love it. And I like how you clarified this is just your genetic makeup for drugs and how drugs interact with your body.
Yes.
That's perfect. Okay, now you mentioned you're going to give us, thank you so much, some resources that we can look into. What if people aren't in Arizona? Would those resources still work?
Yes, they will still
Okay.
work. I have had this great luck to work with many of amazingly talented people who have put together these companies, launched them, and they have been on market, not direct to consumer. This is really a clinical market. So you're going to need a prescription from your physician to actually have this testing done. The quality of service, the quality of the testing that they do, and how this is regulated, I would feel comfortable. And actually, we did have my family member and actually other family members do the testing through some of these companies too.
I love that. Thank you so much for coming and sharing. Is there anything else I didn't ask that you think would be important for people to learn about or to know?
Well, first of all, it's always a treat whenever I get to spend some time with you. I so admire what you're doing and the resources and impact that you have created for people and community. Natalie, I am in awe of all of the moving pieces that you somehow put together and transformed lives. So thank you.
Thank you, Adriana.
My pleasure. As far as what I would say as a takeaway point, here's the thing. I'm a patient myself. I'm a healthcare professional myself. I know what it means to be on both ends of the table. It's really challenging to be a patient or a patient's advocate. You have a lot on your shoulders. I would say what you should, and I am pretty certain when I say this, you guys are, or your folks are doing it here, please continue to advocate for yourself. Don't be complacent. It's easy to be complacent. It's easy to delegate, to say, okay, my doc is going to do this for me. We are people. We're only people, and our time is limited. How long we can meet with a person. It's not that we don't want to. We do. Most of us have gone to medical profession because we want to help and cure and heal and give hope. But you're limited within a system as far as what you truly can do. So be your own best advocate. Look for these things that could be emerging, emerging technologies and whatnot. Just make sure you're not going down the path of the snake oil. One of the things that I hear people say, oh, I am aging rapidly. And I'll ask them, well, how do you know that? And they'll say, I should not be taking this medication because I'm aging rapidly. And I'll ask, oh, tell me more. How do you know about that? And they'll say, oh, I have done this biological clock testing or aging test that now are definitely popping more on the market. And really, if you peel the layers again, and if you sneak under the hood to see what's really underneath there, yeah, there are a couple of these methylating genes, which, by the way, pharmacogenetic testing also will tell you. A few of these methylating genes that have to do with how your body essentially processes things that can impact how you age. You realize, oh my gosh, it's only 1 or 2 genes. We have 200 of these methylating genes. So I am not sure really how accurate all of that truly is. So just continue to follow people like Natalie who are providing these amazing resources for you.
Okay, one last question.
Yeah.
Sparked.
Yeah.
We've said a couple of times, like, be careful of certain companies going down the snake oil. Are there things we should be looking for to say, like, this is reputable, this is good, this should be a red flag?
Oh my goodness, Natalie. So I wish that I can tell you X, Y, and Z. It's really challenging because there is some truth. So, okay, you look at the platform, the testing platform, and they'll say, we will reverse your age 10, 20 years backwards. And you hear all of these things that you want to hear. I mean, I know that I've definitely looked into some of them. I'm like, oh my God, sign me up. Let me see first what's in it. But in concept, sign me up. So it is really challenging because the marketing is done very cleverly. And you also have this now world where you have influencers and people that this is human nature. I would rather do a test that a colleague or a friend of mine or somebody that I know or have some sort of a connection with told me that they have done and had good results. So what I'm trying to say is the following: be cautious of these grandiose claims, because right now there are some lone players. But what I overwhelmingly see are companies that are trying to make quick buck out of people's desire to live longer, healthier, better, reverse some of these chronic conditions and so on. The first thing that you want to look for, is it a CLIA certified lab or not? CLIA, is it certified or not? Do they have any sort of thing on their website or somewhere where it says FDA pending approval or FDA approved test? Usually if it's FDA approved, they have gone through the rigorous process to say what they claim they're doing really is what they're doing. So those are the 2 low-hanging fruits that you can look at. And if you don't have any one of those, I would put the question mark next to that test.
Super helpful. Thank you so much.
My pleasure.
Careblazers. Okay, it's going to be my goal to get this testing done by the end of the year. After hearing all of this information, what about you? Do you think this is something that would be helpful for you, for your loved one? I'd be interested in your comments. You can leave them below. And everybody, please leave so much love to my amazing neighbor, friend, and super amazing pharmacist, Adrijana Kekic. Thank you so much.
Thank you. The best of luck to all of you. And I wish you a life lived in optimal health and the sense of community that I know that you have created here with Natalie. What a joy to be part of this. Thank you so much.
Thank you so much.
Also, Nico gets a belly rub for every person who subscribes from this video. So if you haven't already, click the red subscribe button. It's totally free. And Nico says, thank you very much.